Good evening, ladies and gentlemen, respected doctors, professors, colleagues from Asia and also from other parts of the world. Welcome to the first of the Federation of Asian Organizations for Radiation Oncology, or FARO, webinar series titled Radiation Oncology Services in Asia, Sharing and Exchanging Experiences During COVID-19 Pandemic Era. My name is Maya. I'm from Iros, Indonesia, and it is very nice to meet and greet you all here today. We are very honored to have all of you here, distinguished members of radiation oncology societies from various countries, and we are very excited to learn from each other's experience during the difficult time of COVID-19 pandemic. So today is the first session of what we hope will be a collaborative platform in the long term on the regional level at least, where we hope that many developments, breakthrough innovations and problem-solving solutions that may benefit all of us may be found. And I truly believe that these sessions will be fruitful for all of us. And we are here joined by the respected FARO officers, advisors, and council members. And 7 countries' representatives are ready to share their experience during the pandemic with us for the first session today. So before we begin, for those of you who might not be familiar with the Zoom webinar features, may I briefly introduce. On the bottom of the Zoom screen, your Zoom screen, there is a Q&A box. You can click it and type in your question at any time during this webinar. And kindly proceed with your name and country. And the speakers or chairs will answer your question during the Q&A session after the presentations, or they will write their answers down for you there. Also, for interactive session, if you would like to speak or ask a question, you could click the button raise hand, and then the host will allow you to speak on your turn. Now, to start our event, I would kindly request the president of FARO, Professor Shyam Shrivastava, to please give his introductory speech, which will mark the opening of our FARO webinar series. Professor Shrivastava, I hand over to you, sir.
Thank you, Mayang, and good afternoon and good evening in some places to everybody. And I hope that everybody is safe and healthy. And I really thank everyone who have joined the FARO first webinar, and I must thank the entire team, especially the people who have come from the leadership, especially from the Indonesia, that Mayang, Professor Tati, and the whole team has organized this meeting. So I really thank them for such a meeting which has been organized. During last 6 months, during this pandemic, a lot of changes have happened in the radiation oncology. And it is worth to know that how we have really done with the problem which we have been facing for all these years. We have been hearing a lot from the Western countries, especially from the US and the Europe, that what needs to be done, what has been done, and many of us have been following this, the various the guidelines which has been given. And also it will be really nice that in our Asian countries, how the people are coping, how the people are doing with the COVID pandemic, with the radiation oncology patients which we are treating. It will be great to hear from them. And we learn from each other that what further we need to do. When we look at the FARO programs, we know the LDP program is going very well. We are seeing a lot of leaders which will come in the futures from the Asian regions. The second thing which is also there, which the newsletter which will be reaching to all of you, and I will request everyone to contribute for the newsletter so that we know each other what we need to do and how help each other in bringing the quality of radiation oncology in our area. So what we need to do, we need to become much more stronger and do some collaborative study, do communicate each other, there should be a good teaching, good exchange program with all of us so that we uplift the radiation oncology in our area. And I'm really very thankful and really hopeful in coming period of time that the FARO, which has really done in a short period of time all over the globe, that it has got a recognition that we should also come with the quality which we are producing. And we have always been talking to all of us that the kind of treatment, kind of patient which we are getting are relatively different than we have been doing with the Western countries. So we have to have our own guidelines for our patients. And I'm sure with the interaction and collaboration with all the participants, it will be possible. And I really hope that you will enjoy this webinar, 2 days webinar, today and 9th of the next month, that we will come to know how our countries are doing so that we put forth the guidelines, we'll put forth the maybe kind of white paper will come up so that we know each other. And I think whenever the time is appropriate, we all will meet each other and really communicate. And I must thank the Indonesian group for bringing this webinar. Thank you very much. Mayang, to you.
Thank you very much, Prof. So let us now begin our panel session. I kindly introduce our distinguished session chairs or moderators for today, Professor Soehartati Gondhowiardjo, or Professor Tati, the president of IRAS Indonesia, who serves also as the organizer for this first webinar series, and also the immediate past president of FARO. And also will be joining her, please also welcome respected Dr. Miriam Joy Calaguas from PROS Philippines, the current Vice President of FARO. So to Professor Tate and Dr. Miriam, I hand over the session to you, please.
Please, Miriam.
Doctor, I think it's still mute. Your mic is not on. Yes.
Thank you very much, Dr. Mayang, and good evening to everyone, and to my co-host, my very dear friend, Professor Tati. How are you all tonight? And we are in different time zones, but not too far from each other. I think some are still working, but us, we have already returned home. And so welcome to the first FARO webinar series. And we are very happy that after a series of meetings and discussions by the FARO officers, yes, during the start of the lockdown, we have been meeting every month. The officers have been meeting every month, trying to discuss what things to do. So tonight will be the first activity after all the planning that we had. And so we're very happy that finally we came up with these activities. So FARO officers and council members, we would like to thank Professor Tati and her working team. You have met and heard Mayang. The Indonesian team, they were the ones who organized this tonight. And so we're very happy that also the speakers from the different countries will be presenting tonight. Because right now, as Dr. Shyam said earlier, amidst the COVID-19 pandemic situation, the world is facing a multitude of challenges, which also includes the radiation oncology services uh, all over the world. And because of this unprecedented disruption, it affects the entire healthcare system, including us, the healthcare workers, and our patients in radiotherapy. And we see that there's still rising number of COVID-19 infection. And only this afternoon, before joining this meeting, I heard in the news that there's also rising infections in Europe. So FARO has identified an urgent need to issue safety practice recommendations among radiation oncologists and also the staff and the patients. So therefore, we decided that FARO will come up with a webinar series. This is part 1, and there will be part 2. So that there will be, tonight, there will be 7 countries to be represented, and the remaining countries will present in the second, in the part 2. So that during this COVID-19 pandemic era, the countries included can share. What is important is that we can share our challenges, and not just challenges, but we can also share our strategy in how to overcome the current crisis. So thank you, and I'd like to call on dear friend Prof. Tati to give her remarks.
Thank you, Miriam. Thank you very much, my dear friend. Hi, everybody. Good evening, or maybe good afternoon, or some of you. Very, very happy to be here together and in a healthy and safe condition, uh, all of you all. And hope that all of us will safe until we can pass this COVID pandemic. I just want to also to say hello. We have here Professor Nakano is also here, and also I saw that Professor Billy Manga is also here. I'm so very happy that finally we can be all together in this virtual event. And also I heard that Dr. Zubi is also from IEA, and Ben also will come to join us. And I know that Professor Kovacs also from Ungar is already also here. So, but anyway, welcome to everybody. I hope that all of us will enjoy our meeting today. And for the first speaker, I would like to ask Professor Dr. Tomoaki. Everybody know already Dr. Tomoaki. Dr. Tomoaki is our Deputy Secretary General. He is the radiation oncologist from Fukushima Medical University. And Dr. Tomoaki will present a bit about the summary of the survey about how the impact of COVID-19 in our region. Please, Dr. Tomoaki, the time is yours.
Thank you, Tati. My name is Tomo, and I would like to present about the survey that we conducted late March this year, just to set up the stage for the discussion later. So let me, is the screen shared? Wait, hold on. What's going on?
Yeah, it's okay. We can see already your PowerPoint.
You see it in the big window?
Yeah.
Okay. So this survey was conducted late March this year, 6 months before, and we all know that everything happened afterwards is completely changed our practice in our life. So this is just how it was 6 months ago. We did the survey among FARO countries, and 12 countries responded. This was the COVID situation at that time. So we asked 3 questions. The first was that was there any interruption of therapy? The second was the hospital or the department in any emergency mode? The third was the society ever provided guidance or advice considering the situation? So the first question was, has any of the radiotherapy center experienced radiotherapy interruption? The question, the answer was 5 answered yes. So it was less than 50% of the countries. And how much was the interruption? 2 out of the 5 responded 51 to 99%. So more than half the centers were interrupted, whereas the 2 said less than half. The second question was that the any of the radiotherapy center are in the emergency mode of operation other than the regular infection prevention measures. So this question, only 5 answered yes. half answered no, which is surprising considering the present situation. So interruption and the emergency mode, about 60% was in those mode. So the last question was, has your society issued any statement, advice, guideline regarding the COVID-19 infection? 7 out of the 12 answered yes. And so this was how it was 6 months ago. About half were affected, half were in the almost regular mode. Let's hear how it is now. So that is all for me. Thank you. How do you unshare the screen?
Thank you, Tomo. Thank you very much. It's very interesting information that, but it is done when we had beginning the COVID-19 pandemic. So maybe it's already changed. Maybe it will be nice if we make another survey like this. I hope that I'm sure that everybody, any member countries will join the surveys nicely. So thank you, Tomo. If there is a question, maybe you can write in the QA box, and then we will answer the question later. So for this, we will go next to the first speakers. It will be Dr. Yunlin Yi from China. So Dr. Yunlin Li is a professor, vice chairman, Department of Radiation Oncology, National Cancer Center, Cancer Hospital, Chinese Academy of Medical Science. Now he is the secretary of CESTRO, Chinese Society of Therapeutic Radiation Oncology, and also the treasurer of FARO. So Dr. Yun Li, the time is yours, please. You are still unmute. Please unmute.
So thanks, Professor Tati. So I'm very glad to be here, and I'm very happy to meet you on the online. So I will be, on behalf of the CISTRO, I will be introduce the current situation and strategy of anti-COVID-19 in China. So nowadays in China, we have totally confirmed patients is about 90,000, and about almost 5,000 patients was died. And nowadays we have confirmed patients about 400, and about 400 patients as asymptomatic infection. And nowadays, most of patients came from the other countries, imported from the other countries. And this data sources from the national and local health authorities' daily information announcement. And China have achieved strategic victory of anti-COVID-19. Now is in the status of normalized prevention and control. There were no new domestic cases for more than 40 continuous days, but unfortunately, two cases was reported yesterday in the Qingdao, and there are totally 339 cities have patients, but nowadays only four cities have the current patients. And on September 8, there was a national celebration ceremony was held to celebrate the victory for anti-COVID-19 in China. But nowadays for the world is maybe is another situation. So the patients was increased nowadays, and even in our region, I think maybe the India the patients is increased rapidly nowadays. So current situation in China, the strategy for anti-COVID-19, this is we called a national and people's war from January 50th to February 19, 1 to 6 edition of Protocol of Diagnosis and Treatment for COVID-19 was republished by National Health Commission of the People's Republic of China. And on March 4, the 7th edition was published. And August 9, the 80th, the newest one, edition was published. This protocol is used as guideline for screening, diagnosis, treatment, education, and the protection of COVID-19 in China. And this is a questionnaire from the FARO. I will be introduce the research service in China. So I use our department as a sample. So average number of patients treated per day before the pandemic in our department is 560 to 600 per day in our hospital or our department. So when COVID-19 outbreak in the end of January 2020, it is Spring Festival days in China. This is a slack season for cancer patients treatment. Even though the first day of Spring Festival on January 28th, we still have almost 500 patients need treated. But at that time, we stopped receiving new cases at that time. So we only continue our treatment these patients. So they are not, then the number of patients decreased rapidly from 300 to 800 to 150 at the end of February in our department. And then on March and especially for April, the patients gradually increased. And nowadays is about 400 patients per day. And the workload is limited at 85% by the local government. So how did they handle MDT in the pandemic situation? Yes, most of the time, the MDT was done by the virtual meeting or telephone web chat. We have no physical meeting as MDT. At any specific protocol to treat cancer patients with confirmed cases of COVID-19. So, if the patient was confirmed as COVID-19, the first thing is treat the COVID-19. So most of cancer patients with confirmed COVID-19 were mild cases in China, although the ratio of severe cases may higher than the health population. Most of them can receive normal RT after recovered from the COVID-19. And the next question is, what exactly have your department or society performed to deal with this situation? So during the COVID-19 pandemic, the most important thing for RT community is protect our current treated patients and health care workers, make sure not infected by COVID-19. So we take these measures. So first, screening patients according to the national regular before administration into the hospital, including epidemiology, history, body temperature, blood test, chest CT, nucleic acid test are strictly required. And also this, the same measurement to the health care worker. If the health care worker living working city, he should have the nucleic acid test before he returned to the work. So lower down the treatment number of patients and change fractionations for conventional to hypofractionation, especially for the breast cancer. And nowadays, almost all of the breast cancer patients we treat hypofractionation in our department. The inpatients were not allowed to leave ward except to go to the RT room without family visit. And one room first, and then two patients for 3 persons room. With 1 to 2 weeks observation, the patients can merge into the same room. And only one patient in the waiting area during the pandemic to avoid cross infection. And working environment sterilization is daily practice. So the daily practice of anti-COVID-19 in China radiotherapy committee. The first thing is epidemiology screening. We use internet work and big data. Every people have a mobile phone. In his mobile phone has a health kit. Each person have a app in his or his own phone. Big data and face recognition technique initiated by the government could tell the information of the health status and could trace the person of the city he had gone. People need to show this to us before enter the hospital and public areas, including supermarket, hotel, and regional area. And this is a national policy. All these people should obey. And here is the screening before the entering. Epidemiology survey and the temperature measurement, showing the health information through the app. And body temperature measurement. Everybody should have body temperature measurement before enter to the treatment areas. And also we have automatic temperature machine. And all the people were asked to keep social and physical distance 1 meter, at least 1 meter separate is needed. Wow. And health work protection. The RTT wear the PPP during the pandemics, but nowadays the only we do not wear this PPP. And use the face shield to protect patients and to protect the environment. And work environment sterilization use ultraviolet and the drugs to sterilize the environment. And this what we nowadays the daily practice of our department and all the department in China, how the anti-COVID-19. Thanks. This.
Thank you, Dr. Junlin, for that very, very informative presentation. I'm sure there will be a lot of questions from the audience, and the participants are encouraged to just write their questions on the Q&A below. So we move on to the next speaker, and the next speaker will be Dr. Anita Bustam from Malaysia. She is an academic clinician in the field of clinical oncology at the University of Malaya Medical Center. Anita, who is also a dear friend of mine, focuses on breast, lung, pediatric, and brain cancers. And she has a lot of research activities, and she's also involved in training registrars or the residents in her hospital, which we had an occasion to visit in Kuala Lumpur. In the international arena, Dr. Anita has also been involved in several IAEA projects and collaborative work with CRO and FARO, promoting education and scientific exchanges in radiation oncology. May I call on now Dr. Anita Bustam from Malaysia.
Thank you, Miriam. Thank you for the nice introduction, and hello, everybody. Glad that you could join this meeting. Can you all see my screen?
Yes.
Okay. Basically, again, I'm going to talk about the situation in Malaysia and in particular impact on radiotherapy services. Just a bit of statistics. This is Monday, 21st September. And this is actually from the Ministry of Health portal or website in Malaysia. So we have this daily update similar to what Dr. Jun Lee showed just now. I think they have very similar sort of like statistics coming from the Chinese authority. So as of 21st of September, we have just over 10,000 confirmed cases, and on that particular day, 57 new cases. And this is the breakdown of the new cases. We have 6 imported, 6 local cases but non-citizen, and 45 cases of local citizen. And recovery rate, just over 9,000, patients have recovered, which makes up about 91% sort of like, patient recovered. And our death rate is about 1.26%. So we have 130 deaths. So I think we perhaps have a couple more this, last couple of days. And there's still just over 700 patients still being treated. Most of them are actually quite okay, non-ICU patients, but 9 was actually on ICU. Just to give you some idea, that's Malaysian population there. And that's just the figure in numbers. And as this is actually every day we will get this. We have 14 states in Malaysia. So they will tell us how many cases from each state. Now, with regards to public health measures, strategies, and regulations, I actually got this, interestingly, I got this thing from Wikipedia, this information. So, and I saw some of the countries, I think like the Philippines, they also have some, similar sort of information on Wikipedia, and I can't remember whichever country, but there we are. So I think, again, it's maybe similar to what's happening to most other countries during this period. We had our sort of like the start of lockdown, if you like, on the 18th of March. And currently we are still sort of like in so-called movement control order, but we are in the recovery phase, which is here. So from March 18 to May the 3rd, that was the first lockdown period. And during that period, there are some towns or in Malaysia, which you can see quite a significant number of COVID cases. We have clusters, and in those areas you may actually find areas where they have so-called enhanced movement control order, whereby people from that particular village or town are not allowed to travel out, neither could people travel into those places. And then as things got a bit better, as the rate of infection seems to be reducing, we went through a second phase, conditional MCO, which is movement control order, and that's from May the 4th until June the 9th. And during this period, you see that more shops are being opened. I mean, the first stage, basically, hardly anything is going on. Everything's shut down. The only thing that was allowed was supermarkets, something like for groceries, just the absolute necessities. Otherwise, everything else is actually closed down. And then during May to June, a bit more shops are open, but then you have to have, quite strict criteria when you go to the shops. You have to, similar to what's happening in China, we have like an application on the phone that you then record, your health status on the day, and it captures which shops you go to and so on and so forth. And now, as of June 10th, we are in the so-called recovery phase. But I must say that, from June to maybe July, August, yes, the number of cases seems to be plateauing, but in this month, it seems to be rising again. So we are sort of like anticipating whether we will have to go back to conditional or even hopefully not, this initial stage. But at the moment, as of, this period, more businesses are open and schools are open. Now, in terms of testing, these are some of the people, like individuals where COVID testing is mandatory: symptomatic individuals, close contacts of positive cases, individuals in high risk areas, Malaysians returning from abroad, pre-surgery screening, home deaths, meaning people who died at home or brought in dead and suspected of having COVID. So all of them actually, it's mandatory to test them, because if there are COVID-19 positive, then there is certain SOPs with regards to burial and so on and so forth. Now, in terms of testing facilities, it's available in designated hospitals, both public and private. We do have community clinics who could actually also do COVID testing, drive-through system. And in fact, if you are not able to go out of your home, you could actually call. There are numbers which is actually advertised in the Ministry of Health websites. You can call in service. They will come to your house and actually do the swab test on you at home. Now, in terms of surveillance, in terms of surveillance method, again, I think it might be similar in most other countries. We have this, QR coded bracelets for these are people who are in quarantine, and to ensure that they remain in quarantine, so they have these QR coded bracelets, and also this mobile phone apps. And active case finding is via targeted approach, detection, contact tracing, screening, and testing of high-risk target groups. Now, what about our radiotherapy departments? Safety measures, I think, again, very similar everywhere. I think most of our departments around Asia or even the world will have this, screen for COVID symptoms, all staff and patients visitors. Now, it's quite interesting because Dr. Jun Lee mentioned about the staff having to have regular tests, like the nucleic acid test, which is like, and unless you're tested negative, you can't come back to work. Unfortunately, we don't have the capacity to do that in Malaysia. So it's just mainly symptom screening. So you only get tested if you actually, you are suspected of maybe, you may have COVID, or you have come into contact with, people with confirmed infection, and the usual temperature check. And we have the so-called entry visa to get into the hospital department, which is usually just, on your phone. And then we limit the entry points into the hospital. And it's like a one-way entry and exit traffic system within the hospital. So people can come in through one door, but exit through another door. The usual face mask, sanitized distancing, crowd control, sanitizing workspaces, and of course, for the staff especially, we all have to undergo training for safety protocol and use of PPE, and designated area for, the person under investigation and PPE room. And there are also like work from home option for some staff, not so much for the hospital staff, because we were, at least for my hospital anyway, we became COVID-19 hospital. So we weren't allowed to take any leave in actual fact. We all had to come in and actually be prepared to manage, COVID cases. But a lot of other sort of like institutions, especially non-medical, non-hospitals, and most of them were working from home. Now, I think we are quite, I suppose, fortunate because in the whole of Malaysia, there was only one center where there were people or staff, radiotherapy staff with confirmed COVID-19 infection, affecting one oncologist, one junior doctor, and one daycare nurse. And what happened, obviously, because a lot of these people are, people who are in contact with the affected personnel, had to be quarantined and had to actually go for COVID testing, and the whole department was closed down for a few weeks. And then because of this, upon reopening, that particular hospital decided to actually split the radiotherapy staff into two different teams, so that if one team is down with COVID, at least the other team can still treat, patients. Fortunately, there was no major infection, a couple of months later, and things reverted to usual. What about the impact on radiotherapy services? I think this was again from the questionnaire given to us. I've just sort of like summarized. They were asking about workload and waiting time to start RT. I don't actually have actual figures, but I've spoken to colleagues from various hospitals. Just a general feeling during that peak period, initial stage of lockdown, the RT radiotherapy patients reduces to about 2/3 during that month, and then gradually increasing. And currently we are more or less back to normal, I would say. And obviously the waiting time, because of, because of this, it's slightly prolonged during early stages of the MCO. MDTs, again, I think similar with other places, is all virtual, but until about a month ago, as the cases were coming down, some MDTs have reverted to physical meetings and some bit of a combination. Do we have any specific protocols to treat cancer patients with COVID-19? Now, I have to say, we don't actually have a written protocol. The understanding, most centers, basically, if a patient undergoing radiotherapy tested positive for COVID, most centers will withhold treatment and transfer the patient to a designated COVID hospital until recovery. Because again, not all hospitals in Malaysia could handle COVID cases. So there are a lot of cancer centers where they are not, COVID-19 hospitals. So they have to transfer the patient to another hospital for COVID treatment, and they will only take the patient back once the patient has recovered. And action by Department of Society. Now, in Malaysia, at least, all the hospitals, during this period and until now, we have to follow the guidelines set forth by Ministry of Health. So in a way, it's quite easy because we just follow and that's it. But of course, there are within each department as to how you want to manage your patients, who should be prioritized for treatment, then yes, we develop those internally. But otherwise, all the other guidelines, we have to follow those set by our Ministry of Health. And again, we have to attend all this training. And departmental guideline, yes, we actually then, I think all of you can identify with this. I'm just showing you what happens to me. And again, maybe the patients go through the same thing. So I come in the morning to work. Now I have this thing. And then you can see this, right? Again, this is very familiar now. So in the lifts, you have, you can only fit this so many people. And when I come up from the lift, this is going to my department. You see these boxes on the floor. It is again, like if you have a crowd, then again, you have to stand in these boxes, queuing up to get into the, the clinic area here. Then I get to my office. This is my standard hand cream, if you like, these days. So hand sanitizers, and this actually wipes for the furniture, this spray, doors, handles, phones, whatever. This is like, this combination. Then if I want to have a cup of coffee, I actually go to our pantry room. Sorry, you can't see this, but basically what it says here, maximum 8 people in there. So I normally open the door slightly, stick my head in. There's more than 8 people, that's it. I have to wait and I have, come back later, something like that. And this is just showing our radiotherapy planning. This door here is actually going to our simulator area. So then patients, because of distancing again, I think you've probably, have the same thing in your hospitals. So you have to sit there, that you're not allowed to sit there, kind of thing, for distancing. And this is actually, you have to press this button to get into the radiotherapy area. So basically what it's saying here, you can maybe just about see the word hand rub, just to tell patients and staff, you actually have to use the hand sanitizer before pressing the button to go into radiotherapy. And that's me and my colleague, Marniza. I think, don't know, some of you may have met her. She was a speaker in the FARO in Shenzhen last year. Okay, so that's all I've got to present from Malaysia. And this was taken very recently. We decided, okay, never mind. We should have, for memory, like COVID-19 department photo, and again, distancing there. All right, thank you. Back to Miriam.
Thank you, Anita. It's very interesting. Hope that there will be no other wave of new cases of COVID in Malaysia. But I thought that the number of cases is already very low. So thank you very much. There will be a lot of questions from the audience, but we have to go on with the next speakers first. For the next speaker, I would like to ask Dr. Sutita. Dr. Sutita, are you there?
Yeah.
Sutita is a radiation oncologist from Mandalay General Hospital. I have a friend in Mandalay, Dr. A. You know that?
Yeah, Dr. A, Professor A.
Professor A. And Dr. Sutita graduated from the Mandalay University of Medicine in Myanmar. And he is now working in the Department of Radiotherapy, Mandalay General Hospital. And overseas training, he was in Singapore, in India, in Chennai, as well as in Tokyo, Japan. It's your time, Dr. Sutita. 7 minutes time for you to explain what is happened in your countries due to the COVID-19 pandemic, please.
Thank you very much, Dr. Okay. Go. Okay. Good evening, everyone. I'm Dr. Sodia from Myanmar, and it's a great pleasure for me to present this for a meeting. Okay. So before going to the COVID situations, I like to tell about the Myanmar situations. Myanmar has a population of 54 million population, and about 70,000 new cases of cancer patients a year, and the number of deaths is about 50,000 annually. We have only 9 cancer centers, 4 governments, 2 military, and 3 private centers. So, it's like other countries, we have been facing with the attack of the COVID-19. The total specimen tested yesterday, the updated data is at 24,000 cases as specimen tested, and total PUI cases is at 11,000 cases, and confirmed cases is more than 7,000 cases. So the death rate is more than 130 death from the COVID-19. We have the 2 peak of COVID-19 infection in our country. It started from March to the August. Within 6 months, for the very first time, COVID infections looked very easy to control for our country. So it's only six people died of COVID-19 and 600 cases infected in the 6 months. So we thought it's very easy to control the COVID-19 infection in our country, but we were wrong. We were wrong. Recently, the situation has changed. In the middle of the August, so the incidence rate has skyrocketed from 600 to more than 7,000 within a month. And the people died from 6 people to more than 130 people in 30 days only. So you can see that these figures. This is the green cycle is showing the first wave of the COVID-19, and another cycle you can see the second wave of the COVID-19. It looks very aggressive and highly fatal. I don't know why. So currently, for the public health measure strategies, currently no city lockdown except the stay-home policy. The government is using, especially the Yangon, Naypyidaw, and Rakhine State. Those are assumed as the high-risk area. So the people are don't allowed to go in and out that area, and they must go into quarantine center if they want to go there. And the night restriction from 12 p.m. to 4 a.m. only. The tests and surveillance, both community and hospital-based tests and surveillance are done. So we have tried our utmost to provide the safety environment for both of our staff and cancer patients. It may vary from center to center, but from the basic measurements are the same. From entrance restriction of the department to duty shift or alternate week without overlapping each other of the staff, and to avoid the departmental meeting or conference. First step, the phone communication only is advisable to our staff, and to avoid the contact and to reduce the workload we have planned and to shorten the radiotherapy regime, and the protective barriers are are applying for all the specialist OPD and all the clerical desks, and to reduce the number of patients attendance, and also we encourage teleconsultation with the patients, and to get on the non-essential face-to-face follow-ups for the doctors. For the sake of the patients, we encourage the patients, from wearing the gloves to social distancing, so according to the WHO guidelines. But in terms of the social distancing, as you all seen, it is quite difficult for us because our centers in Myanmar usually has the less space with the crowded people, so it is almost impossible to achieve the good social distancing. So these figures are from my department showing the good method of the social distancing and the bad figures and also good ones and the bad ones from my department. So there are so many impacts on multiple impacts on multiple layers of the people and the organization and also the country and the globe by the COVID-19. The number of the patients in our country declined. They are taking radiotherapy, and also the increased number of the folders, increased number of the treatment interruptions, and some patients disappear even after CT simulation because of COVID-19 infection. This figure shows the number of the patients received the radiotherapy treatment at the Yangon and Mandalay centers, so from January to July and September. So in this figure, you can see it is the lowest in the April. So it is it's because of not only due to the COVID, it's because of the public holidays in our country. So overall the number of patients receiving radio services declined due to the COVID infection. From all 9 centers, so we estimated 1,000 cases per day, but during the COVID area, it reduced to less than 800 per day. Our staff has faced many social and psychological problems. Some are not allowed to stay at their hostel because they are thought to be the carriers, and they are not willingly allowed to go and to stay at their hostels. It's a kind of the huge discrimination, and reduce in the number of the staff member because of the positive case, and also the quarantine, and also finally the financial crisis they occurred. So in Yangon Center, one radiation oncologist was infected, and 8 staff were infected by the COVID-19 infection recently, but there is no confirmed cases in other cancer centers as in the country. So only one radiation oncologist was infected. For those confirmed cases of our staff, so we do whatever we have to do according to the local guidelines and according to the local authorities. But generally, we provide our staff to get the proper treatment and to take rest and to restart the work after recovery. There is no lockdown or shutting down of the departments or radiology centers currently. Yangon Cancer Centers is giving the radiotherapy services very carefully, even after they have found 1 cases. In terms of the multidisciplinary teams, we prefer by phone and by communication, and also the video conferencing if possible. In terms of the radiotherapy treatment protocol, the curative and palliative intent will keep us the pre-COVID time and treatment the same, but we prefer hypofractionation region. For emergency cases and palliative cases, safe intent have changed the practice. So the radiation regime should be as short as possible, like single fraction, 1 to 2 fractions, and instead of the 5 to 10 fractions. There is no specific protocol for confirmed cases of the COVID-19, but we usually follow RCR guidelines and NICE guidelines. For the confirmed cases, we have planned to delay the start of the radiotherapy and stopping ongoing treatment temporarily until the patients get recovered. If the treatment is palliative, and alternative palliative regimes will be a choice. And each case should be discussed with the infectious disease specialist to weigh the risks and benefits of the radiotherapy treatment. One treatment needs to be continued to consider replanning with a hypofractionated regime and to treat the patient as the last case of the day with a staff on the full PPE protection, and subsequently the patient to be transferred back to the isolated room as an inpatient. And during treatment, the patient and evolved staff will need to don an appropriate V level. So from an organization point of view, oncology treatment should be given even in an infectious time. And this is also true for the patient. He or she should have the proper radio or radiation treatment without any disruption. So to ensure such continuity of the services, the following measures will be implemented in our departments. So to do the safety protocol for patient, to reduce the workload, careful manpower planning, and additional steps are also required to help with additional duties such as temperature screening, triage, and contact tracing. And patient screening, temperature monitoring, patient and staff education are still needed to ensure the adequate medical supplies, ensure continuity of the communication channels, and manpower considerations, workload management, formation of the care teams, and remote planning if the facility is provided. Thank you very much for my presentation.
Thank you very much, Dr. Sothia, for sharing with us your experiences in continuing to provide radiotherapy in your country despite the difficulty that is brought about by the COVID-19 pandemic. Thank you so much. And now we'll call on the next speaker from India, Dr. Ajit Gandhi, and he's a young radiation oncologist. In fact, he is a product of the FARO Ph.D. or the LDP, Leadership Development Program, which the FARO has started with, I think Professor Tati started this program to develop our young radiation oncologists to become future leaders. There, that's his picture, Dr. Ajit Gandhi. So he has been consistently receiving gold medal awards in schools that he studied in India, from New Delhi, Kolkata, and also he was a fellow at the Tata Memorial Hospital. He also went abroad for some fellowship training at the Memorial Sloan Kettering and others. He's also very active in research work. He has presented oral papers, full paper presentation, posters, and he's also done some invited guests, done some guest lectures, either nationally or even internationally. So let's welcome Dr. Ajit Gandhi to provide the paper from India.
Sorry, doctor, your mic is still muted.
So am I audible now?
Yes, thank you.
Yes. Sorry for that glitch. And thank you, Dr. Miriam, for that kind introduction. And I would be presenting on behalf of Association of Radiation Oncologists of India. And it was a wonderful initiative from the FARO for this webinar series. And it was also wonderful to learn experiences from different countries. India, as you know, is one of the most populous countries, and we have had our own challenges and difficulties. And in the subsequent slides, we would see what are these. So the first part is general COVID situation affecting India. So globally, we are now second in terms of cases of cumulative COVID-19 cases, just behind United States, and maybe we will soon surpass USA and become number one. At present, we have around 1 million active cases, 4.5 million recovered cases, and around 0.1 million patients have succumbed from COVID-19. As far the COVID-19 testing goes, so far cumulatively around 66 million samples have been tested, and every day around 0.1 million samples are being tested. And there is a huge geographical disparity. If you see here in the map, in the region wise, the number of COVID cases is differ as per the regional. So we had one of the most strictest nationwide lockdown, which was announced on 24th of March 2020 by our Prime Minister of India. And there was a severe ban on people. All shops got closed, the commercial, private establishment, all educational training research institutes got suspended, all places of worships, all non-essential public, private. So it was one of the strictest nationwide lockdown. And it went on to several phases. And now we are in the phase of unlock. And currently we are in the unlock 4.0 phase of this thing. So from the very beginning, however, the government of India has taken the initiative and they have been consistently issuing guidelines from Ministry of Health and Family Welfare. And the guidelines are basically in terms of travel advisories to general citizens, to hospitals, issuing training materials and awareness materials for the general public. Also, the Indian Council of Medical Research, which is considered to be the apex body for medical research in India, has been consistently updating the guidelines on COVID-19 testing about what tests to perform, which to perform, and which centers should be licensed to perform it, etc. And these all can be accessed on these website links from this PowerPoint. Our society was also very prompt in the very beginning, and it issued an advisory by the Association of Radiation Oncologists of India. And this was published in the official Journal of Cancer and Research Therapeutics. There was also another publication which was endorsed by EROI, COVID-19 Pandemic Radiotherapy Precautions and Preparedness. And this was from one of the best centers in India, Tata Memorial Hospital in Mumbai. And also publications from different other institutes in India. And basically these are guidelines for patient care, outpatient, inpatient care, radiotherapy treatment and machine area, administrative and staff guidelines. And these guidelines also are there on the official web page of the Association of Radiation Oncologists of India. So coming to the second part, how is radiotherapy service impacted by the pandemic? And how is the radiotherapy department in our hospitals adjusting to the pandemic situation? We have all learned in the past 5 to 6 months the concept of physical distancing, sanitization and everything. But even within the same country, different institutes may have different challenges. And we thought that the best thing would be to do a kind of nationwide survey to understand the challenges and practice patterns at different institutes. And this is a 30-point survey questionnaire which was mailed to all the practicing radiation oncologists across the country. And we tried to retrieve response from single institutes. And we analyzed finally the response from 256 institutes and hospitals. And these were just single responses, not the duplicate ones from the institute. So these are basically data from 256 different practicing institutes or hospitals. So mostly around 50% of them are government academic institutes, but around 30% are also private and corporate teaching institutes. What has also happened in the last 5 to 6 months is hospitals have designated on COVID and non-COVID areas in India, and there in the same hospital there are wings which will harbor or treat COVID patients, and then there are wings which will treat non-COVID patients. And if a patient in the non-COVID area turns out to be COVID positive, they are shifted to a COVID facility. And 3 centers also reported that they have COVID facilities just only for their staff. So if they have any patients who turn out to be COVID positive, they are referred to another center which have COVID treatment facilities. Now, has the radiotherapy services been suspended? Largely no. Almost 80% of the centers you see are functioning, but there had been some temporary or intermittent suspension at 38 centers, which is around 15%. And mostly these were because the number of cases suddenly peaked up, they were shut down, and then they reopened and it started functioning. However, in 11 centers, radiotherapy treatments have been permanently suspended because they have been converted into COVID designated hospitals, and they are no longer treating other cases, other departments. Even other departments are shut down. They are converted into COVID designated hospitals. So if you see the nationwide change in the patient numbers on external beam radiotherapy, with the median of 80 patients from pre-COVID had changed to 60 in post-COVID, and there has been a median decreased percentage in the treatment of patient numbers of around 33.3%. The other range of 200%, there has been increase in some centers, but these were largely because these centers were in the process of opening up, and they opened up and started treating. And there are some referral centers which had to treat more patients because other centers stopped. So what are the basic changes in the EBRT practice patterns that most of the centers have brought in? The most important of this is around 70% of them have started using more hypofractionated regimes. 35% would delay or defer radiotherapy. Around 25% would omit CTRT with borderline indications, and 28% have made no change in their EBRT practice. Concerning brachytherapy, there has been problems in some centers because mostly these sources are imported from outsides. There are centers, around 10, who have stopped brachytherapy treatments because there are lack of sources or temporary suspension of OT, or the machine has gone out of order. So from a pre-COVID range of a median number of brachytherapy per center in a weekly, 7, it has turned down to 3, and the percentage change is around minus 50%. So almost half a decline from there. And what changes the brachytherapy practices have made? Around 48%, majority, I would say half of them have made no change. Around 25% would do lesser number of insertions or fractions for cervix, for example, 9-in-2 kind of thing. There have been around 12.4% of centers who have been using brachytherapy before, but now they have resorted to decreased uses of brachytherapy where they already have alternative modalities. So patients who have defaulted or during the COVID-19 or discontinued treatment, 40 to 50% of the patients, you see half of the patient defaulted, and this was only seen in 10% of the centers. Majority of the centers, around 40% of the centers said that the default rate was in the range of 0 to 10%. So looking at it from the perspective of the patient, that why the patients defaulted and discontinued the treatment. So majority of the patients later on confirmed that it was basically because difficulty in reaching the treatment facility because of a stricter lockdown. They also had a fear of contracting COVID-19. Many had job loss and economic breakdown, and due to financial constraints, they were not turning up. There was fear of caregivers in contracting COVID-19. And also 50% reported that there are non-access to diagnostic or other allied departments, because the government guidelines later on said that oncology services, gynae services, and some other services would be mandatory, whereas major OPD services in government colleges have been suspended for quite a long period of time. So the dynamic change in patient was difficult to acquire from the survey, but this is the survey that I've shared the data from our own institute, Dr. Ramanohar Lohia Institute of Medical Sciences. If you see the new and follow-up patient registration in February, the new was to 266 per month, and it was 2163 per month in February. And suddenly, just at the beginning of lockdown, it drastically fell down. It jumped back in slightly in May, and then June, when the lockdown was lifted up, the patient numbers increased. In August, we slightly saw a decrease in the patient numbers, maybe because the number of cases are again rising and the patients have concerns about this. So what do the centers do when a COVID positive cancer patient turns up to them? 81% of them, they would defer radiotherapy and call them after the negative COVID report. If there is a need of urgent radiotherapy, there are 24% of centers who would deliver it with safety precautions. 12% of the centers would refer to another center who would be treating such a patient and who has a facility. And there are 5 centers who are also using radiotherapy for COVID pneumonia, mostly under the trial setting. The safety guidelines have been propagated nationwide by the guidelines, and these are what has been adopted by the institutes. Almost 70 to 90% of them would use a mandatorily N95 mask or face shield. Screening of the patient is done with temperature checks and symptom inquiry before entry. The examination is minimized as far as possible. The OPD areas have been additionally shielded with seats. The contact time with the patient has been minimized. Rotatory work schedules, patients have been educated about these, and the 32% also reported that they started increased use of imaging modalities. The safety guidelines for patient on treatments, around 85% of the center said that they sanitize the machine, the entry gates and handles at periodic intervals. The immobilization cast is sanitized. The seats or the linens on the Linac machines are changed after each patient treatment. Mandatory COVID testing for patient before radiation initiation is in around 60% of the centers, and also mandatory screening of all RTT staffs in 45% of the patients. Periodic COVID testing for patients who are already on treatment is usually not done, but it is seen in around 26% of the centers. The measures that has been taken to safeguard the healthcare workers. So there has been a free and periodic supply of personal protective equipments, COVID testing for symptomatic healthcare worker or the healthcare worker with a high risk contact in 66% of the centers. They are also given free care, including paid leaves in 50% of the centers. And there are centers where they have been mandated to use hydroxychloroquine or ivermectin prophylaxis, but this is around 18% only. Now, the telemedicine usage during pandemic has definitely surged. We have also started using telemedicine, and this is mostly and largely used by around 55% of the centers for follow-up of the patients who have already completed their treatment and they are coming on the routine follow-up. This is also used for on-treatment follow-up who are on treatment for weekly visits. For multidisciplinary tumor board meetings, around 32% have shifted to teleconsultations. For new patient consultation, just 28% of them are using, and mainly they are using it for screening the patients and giving them appointments. And even the doctors who are radiation oncologists, they are in fact in in many centers they are mandated to do COVID-19 postings outside the scope of their departmental work, and this is there in around 43% of all the oncologists. And 8.9% of them have reported COVID-19 positive themselves. If we see the rate positivity for patient staffs and radiation oncology departments, in absolute numbers, around 3,000 patients have been reported COVID positive, 2,600 staffs have been reported positive, and disturbing is 124 number of healthcare workers who required intensive ICU care, or some of them also succumbed to COVID disease. The good thing to learn is around 74% of the centers have already formulated written directives and guidelines for the change in workflow during this COVID-19 pandemic. And mostly they have adopted, around 61% of them have adopted our society guidelines, but they have also endorsed and adopted a modification of ASTRO, ISTRO, and ISMO guidelines. The academic activities during the pandemic time has definitely changed, and it's basically changed in terms of increased attendance to webinar activities at 74% of the centers. Around 50% resorted to online classes as per their existing curriculum. Face-to-face classes were halted in around 50% of the centers, and hands-on training on TPS and brachytherapy has also suffered in around 20% of the centers. The research activities have suffered roughly around 40% each. The new research projects are not being taken up. The thesis recruitment of MD, DNB, these are basically trainee students, have been affected. Recruitment to ongoing projects have decreased. And also there is the willingness of the patient to participate in the study has declined by around 17%. So finally, to conclude, the COVID caseload is on the rise, and the preparedness to deal with this has also increased with due course of time. We have now centers at even the rural areas, the far-reaching areas where we have facilities for COVID testing and also COVID designated hospitals to take care of them. Our society has acted very swiftly in issuing written directives to help us deal with this crisis. And as we saw, this has been adopted widely at many of the centers. The patient numbers on treatment has decreased approximately by around 1/3 for EBRT and half as compared to the pre-COVID time for brachytherapy. And there have been significant changes. They have been adopted in prescription of radiotherapy, chemotherapy, and working aspects overall. The safety protocols are still evolving. Academics and research have suffered significantly, and we need collaborative effort for boosting at least the academics and research. We should move on. And this is the memories from the third FARO annual meeting, which I attended at Bali. It was a wonderful experience, and my co-LDP recipients for the first batch. And together we empower each other. Thank you very much.
Thank you very much, Dr. Ajit. It's very interesting as one of the biggest countries in the world experience facing the COVID-19 pandemic, and we can see that there are impact of the COVID-19 pandemic to the how to run the radiotherapy services in your countries. So we move to another. Thank you very much again, and also to remind us for the Bali conference. So we move now to Bangladesh. Dr. Kazi, Professor Kazi Mustaf Hussain. Are you ready, my friend? Professor Kazi is the director, professor, National Institute of Cancer Research and Hospital, Mukha Khalid Dhaka. He has a lot of training and workshop abroad of the countries, for example, in Vienna, in India, Mumbai, as well as in Philippines and others, and also have a lot of experience working as a radiation oncologist. One of important is the secretary of the Bangladesh Society of the Radiation Oncologists, the SRO, and recently working as a president. Please, Dr. Kazi, the time is yours.
Thank you, ma'am. Can you see it? So thank you very much for the kind introduction. I am Dr. Mustaq from Bangladesh. So as we all know, the initiation of the COVID pandemic in Bangladesh, the first 3 known cases were reported by the government institution in March 8. And every day the government releases a news brief on the incidents of the COVID-19 on day 2201 on 24th 9 yesterday. We have newly diagnosed cases were more than 1,500, and total diagnosed cases were 355,000 plus, and total death was 5,072. Total recovery to 65,000 plus, and total tests were 1,875,537. So these are the tests and the reports. And the government took some initiative on 23rd March by closing the schools and other educational institutes, closing most of the offices and shopping centers and the public transportation, except the emergency sectors like the health, security, police, fire brigade, etc. The government started distribution of food among the vulnerable groups and selling food and OMS, and also some social groups also distributed food among the poor people. The grocery shops and medicine shops were open for a time period, definite time period, and lockdown was not country-wise. It was only some areas, but the infection rates are very high. The movement of the people become very less, and awareness posters, slogans were broadcasted in television, radio, newspapers, and other social media to inspire people to use face masks and sanitizers and maintaining physical and social distancing and avoid gatherings. Government hospitals were open and COVID units were established with a price system. Government quickly built one 2,500 bedded hospital in Dhaka city, the capital city, for COVID patients, and acquired some private hospitals for COVID patients. COVID-19 tests by RT-PCR started in government hospital and later on private hospital. So counteracting COVID-19 in the departments, like other, as we heard from you all, we use thermal scanner and disinfectant tunnels at the entry point of the hospital, especially in my institute, the National Institute. We spray disinfectant in hospital premises regularly. We started a 2-corner for patients who came with fever, high temperature, to isolate them, to separate them for further investigation. Awareness posters, slogans, and using digital board and hand mic also used. And we made an isolated ward for the staff at NICS, at 7-bedded special unit, and a 60-bedded yellow zone for the patients coming without COVID test. We distributed PPE, hand sanitizers, and among staff, and finally we started telemedicine in May, so that we can talk with the patients who are unable to come to the centers. In NICRH, COVID test sample collection started from July. And we worked in a way to avoid complicated treatment and advise less investigations. We worked in small groups of doctors and staff using 7-14 formula till July, 7 days work and 14 days home quarantine. We held tumor board virtually or in a very small scale. Mandatory COVID tests were done before starting radiotherapy, chemotherapy, or surgery. If COVID patients are identified, we sent them to the COVID dedicated hospitals, and that was more than 100 in number. Radiotherapy practiced mostly by hyperfractionation and also some urgent cases. We completed radiation for the ongoing patients with very careful preparation with using PPE for the patients and the RTTs also and the doctors too. We usually talk to the patient by telemedicine, and alternately we use some oral chemotherapeutic drugs and some TICs. There was the patient flow was reduced in number. The patient 50 to 70 patients attended during the March to May period. 100 to 130 patients attended for radiotherapy as OPD basis. And the patients mostly were residing in Dhaka city or residing near the radiotherapy centers. 100 patients attended daycare for chemotherapy. 50 to 60 surgery was done in my institute from March to June and gradually increased in July and August. If we see in April, in OPD, there was 2,572 patients, but in August, in July, it was 15,000 plus, and in August, it was 17,000 plus patients. The daycare centers for chemotherapy, the patients was 3,000, 2,000, 1,900, nearly 2,000, 2,900, and now in August, it is near 4,000 for daycare center for chemotherapy. And radiation patients dropped in May, June, but in July and August, it is increasing gradually. The surgery was done in my institute was 38 in April, but in July it became 95 and August 93. So the activity of BSRO published a COVID-19 guideline on May 31st based on ESMO Astro guidelines. We participated in a multinational study to assess stress levels among the healthcare workers of radiation oncology community at the outset of COVID-19 pandemic with India, Indonesia, and Nepal. We held virtual meetings in May, June, September, and continued virtual academic sessions 3 weekly on the BSRO, but the classes were regularly taken on webinars. And oncologists participated in the awareness programs in the social media, TV, and others. So the sufferings were not less. The number of oncologists infected is 50 in number. RTT, nurses, and other staff in 36 in number. One medical officer working at NICRH, Dr. Asaduzzaman, died of COVID in June 27. So he was not an oncologist, he was a junior medical officer working in my institute. And we, the staff of NICRH, raised a fund of 1 million taka for the family of Dr. Asad. And one Dr. Ashraf infected second time. Reinfection also occurred. He is a student at the DMC, MD student. And number of patients found positive, 122 in our screening. None of the departments were shut down for the pandemic. So in conclusion, we can say despite the loss of one life of a doctor in NICRH and more than 105 doctors in other hospitals, the oncologists and doctors of all other disciplines worked relentlessly to combat the pandemic, along with 2,500 doctors, 7,500 health workers, and 50 oncologists were affected by COVID-19, suffered much, but still in the war against COVID-19. This is the guideline, the ESL guideline for cancer patients in COVID-19 pandemic. And thank you, everybody, for patient sharing. Thank you.
Thank you very much, Dr. Kasi, for your presentation from your country. And we can see that by your sharing that now, after listening to several speakers, there are so many similarities in our experiences and even in our approach. But the sad thing is that losing a colleague, even just one, it always affects us, all of us, when we lose a colleague in this way. So we hope and then pray that there will be no more of this, but we continue to fight and we continue to survive, even as we have to continue working for the sake of our patients. Thank you so much for that. And let me call on the next speaker from Korea. Okay, her name is Dr. Ji Hyun Chang, and she is a clinical assistant professor from the Department of Radiation Oncology of the Seoul National University Hospital. Dr. Ji Hyun Chang, please take the microphone.
Hello, it's my honor to be present here, and I've sent my recorded PowerPoint file to the host, so I will ask the host to play my PPT file.
Yes, thank you. Dr. Mayang, please.
Yes, it's ready, yes.
Good evening. I am Jiyeon Jang at Seoul National University Hospital in Seoul, South Korea. It's an honor and privilege to speak to you today. I've been asked to speak to you on radiotherapy service in South Korea during COVID-19. First, I'll talk about recent COVID cases in South Korea. Total population of South Korea is 51 million, and of those, 2 million tests were performed and 23,000 were confirmed positive. Positivity rate in total number of tests is 1%. Mortality rate of COVID-19 in Korea is 1.6%. South Korea has implemented a 3-level social distancing scheme. In general terms, the first level applies to a small-scale outbreak, the second to community transmission, and the third to a large-scale outbreak. Factors to be reflected in decisions on whether to change levels include the average number of new community diagnoses within a 2-week period, the scale of cluster infections, the percentage of cases involving unknown transmission routes, and the availability of hospital beds for patients with severe symptoms. The current stage is level 2 in South Korea. It means that the average number of newly diagnosed community cases increased to 50 to 100 per day. Under level 2, the number of students attending in-person classes at school and kindergarten is reduced, and the government would also invoke an administrative order banning indoor events with 50 or more people and outdoor events with 100 or more people. Next, I would like to explain about Korea's test and surveillance and active case finding strategies. For epidemiological investigation, basic information including whereabouts of confirmed cases are collected through an interview with confirmed cases. If needed, interview with healthcare workers and family members may additionally take place. In case the acquired information is insufficient, more objective data as medical records, mobile GPS, CCTV footage, credit card records are maybe collected and verified. Information on the whereabouts of confirmed cases are uploaded on websites in order to prevent any additional infection. The contacts identified during the investigation are required to attend healthcare education, have their symptoms monitored, and stay in self-quarantine. Family members, housemates, and other contacts identify epidemiological investigation on the patient's travel and infection routes are subject to self-quarantine for a maximum incubation period 14 days, beginning from the day after the date of contact with a confirmed patient, and have their symptoms monitored. The Ministry of Interior and Safety and local governments thoroughly manage those under self-quarantine on a one-to-one basis. Those in self-quarantine are prohibited from leaving the country for 14 days regardless of their health status. Those who violate self-quarantine guidelines may face up to a 10 million Korean won fine or 1 year of imprisonment. This is our community treatment center of Seoul National University Hospital. This is for the mild cases who do not need hospitalization. These cases include those who are discharged from hospitals after receiving in-hospital care and show improvements but are still in need of treatment, and those who are classified as mild cases with no need for hospitalization. Next question was, how did your department society counteract COVID-19 situation and provide safety environment for patient and staff? We are following the institutional guidelines, and the basic rule is keeping social distancing, wearing personal protective equipment, and we restrict access to hospital and do fever screening to all visitors. For who has symptoms, he or she is moved to an isolated or separated area within the screening station for sample collection. This is a schematic for hospital-level triage and separation of COVID-19 and non-COVID-19 patients in South Korea. To prevent cross-contamination between people with and without COVID-19, patients were first classified at a preliminary triage zone, depending on their severity and infection status. This is distancing guideline in Seoul National University Hospital. Now it is level 2. In our department, there was no confirmed cases until today. We have no experience of shutdown due to numerous active cases or other reasons. Even in Daegu, we had the greatest impact of COVID-19 with the largest number of COVID positive cases in January to February 2020 in South Korea. There was no change in daily practice of radiotherapy in Daegu. This is a brief report from Daegu submitted to International Organization for Medical Physics about their radiotherapy services in Daegu during COVID-19 outbreak. So, to answer questions B4 and C1, we did not change any decision-making and practices regarding radiation therapy because of COVID-19. About MDT, according to the institutional guideline, MDT meeting for the treatment discussion is limitedly allowed in Seoul National University Hospital. And we don't have any specific protocols to treat COVID-19 confirmed cases, as there was no case to date. Our department and society are trying to deal with this situation by following the national institutional guideline. Thank you for your attention.
Thank you very much. Thank you very much for a very informative presentation. It must be some question, but because of the time, please write the question in the QA box. So we move now to Singapore. Dr. Tan, David Tan, are you ready? Dr. David Tan.
Yes. Hi, everyone. Sorry, I'm actually at the dinner meeting, so a bit of a noisy location. So I'm moving somewhere a bit quieter to give the talk. So please accept my apologies. Okay, so Okay, I think I'm in a good location. Is the view very nice for all of you? I think that's okay. All right. Okay. So yeah. Hi everyone. So I'm ready to begin the talk. Just to introduce myself, my name is David. I'm a radiation oncologist from Singapore, Asian American Radiation Oncology. So I have the slides, I think, with Mayang, and would you be able to share those slides, please?
Please, Maya.
Okay. Yes. Can you
Okay.
see?
So yeah, I've got about 15 to 16 slides. And really, I think the point here is to stick to whatever was given in terms of reference so we can keep to the time as well. So next slide. Here is broadly the scope of my presentation from Singapore perspective. We want to look at the timeline of the response to COVID-19 in Singapore, following which we would then want to look at the national healthcare response more from various perspectives. I think from the national perspective, we want to look at the government as a whole, how we responded to it based on the evolving situation with the number of cases picking up, whether it's community or imported cases, and how we responded in the community level. And then we want to also zoom into the national healthcare response from a hospital and healthcare perspective, how the entire medical system was tailored according to our DOSCON response system. And finally, we then go on to a radiotherapy, a radiation oncology specific response as well. So without much further ado, let's go on to some diagrams for our reference. Next, please. So here is a timeline of the COVID-19 outbreak as it evolved in Singapore. As we all know, in December, the first case was actually detected in Wuhan. It did take a while before the lockdown occurred and the news got out. From January onwards, when WHO declared a health emergency and pandemic, Singapore then took some steps to gradual steps to pick up and diagnose those cases promptly, and then eventually to starting with China to bar new visitors in the 14 days. And then later on in March, actually it took a while. We realized that it took almost 6 weeks for Singapore to actually bar all essential travel from every single country. So I think basically this timeline shows that as we have seen in the various countries, sometimes hindsight is always good, but there's always going to be some delay as people figure out what's exactly going on as well. And these are lessons that we learn for the future. So next slide, please. Yeah. Okay. So sorry for these small figures, but I think basically this slide zooms out a little bit and brings us from January all the way to June 11. And it's a very busy slide, but basically I want to point us to the red dot, which tells us the number of cases, cumulative cases, all the way to now. And the blue dot, which actually shows the number of new cases in Singapore and how we dealt with it. So all those little black diagrams actually describe the various measures that Singapore put in place, beginning from the standard regular hand washing, temperature checks, and so forth in the early part. So say from January to March, these basic steps were in place. And then following which in March, when things became a bit more serious, then places of social gatherings such as cinemas, gyms, mass gathering events were actually stopped. And then later on, the health measures then specifically started to kick in. Stay home was strictly enforced from April, and this continued all the way to June. So work from home um, and social distancing and so forth were actually initiated from April onwards. In June, as you can tell, we then transited on to what we call a post-COVID phase 2 measures where we allowed small gatherings of up to 5. We allowed some non-essential healthcare services to continue and all the way to now. And I think Singapore will potentially be moving on to phase 3 eventually, where we slowly release and relax those measures, hopefully with no unintended side effects. So next slide. Okay, so as it is now, I think we are doing quite well. Our number of COVID cases on a daily basis has dropped from a high of maybe 1,000 to about 50 or less cases a day. If you look below total discharge, closely approximates the total number of cases to date. We've got about 58,600 as of today, with about 20 to 30 cases, new cases being diagnosed every day. And I think our community cases are coming close to zero as well. As you can tell, again, our death rates are quite low. I don't want to claim credit. I don't really think it's really due to the very, very highly superior healthcare in Singapore, although it is decent. But I think I suspect that maybe the strains in Singapore are a bit less virulent as well. Next slide. Okay, so let's move on from the timeline all the way to the Singapore national response. I think we are quite fortunate in that we've had prior experience from handling SARS, the SARS outbreak in 2003. I think that really gave us a wake-up call, and following on from that experience, we then refine our strategies. We then initiated a DOSCON system, or rather a disease outbreak response system, to allow us to grade the national response according to the severity of the outbreak as well. In the next slide, which we can move on to, I'll show you the different grading system in the DOSCON alert levels. So we've got DOSCON green, which is so-called normal, mild level, followed by yellow, which is where the disease is severe and spreads easily, but is still under control, thus resulting in minimal disruption. DOSCON orange, where the disease and spreads easily from person to person, and there is some moderate disruption to life. And then finally, red, which is the most severe. So I think in Singapore's perspective, we move on to DOSCON orange, where we remain right now. Although I will say in the April to June period, where we went into kind of an extended lockdown, we were actually a bit in DOSCON red. But as many of you will know, the government probably didn't escalate it due to the elections that was coming up. Yeah, so this is just some juicy bits of news. So next slide, please. Okay, so in the hospital as well, I think this is still again in the general picture. The measures that were implemented according to the DOSCON system mainly pertain to isolate potential cases, how we transport them, ambulance systems, and so forth. And to that end, practice exercises were carried out yearly on paper as well as on a practical basis to drill our systems on our responses to the various DOSCON levels. At the same time, we also know that Singapore built a dedicated hospital for infectious disease in 2003, and I think this came into very much good use in our response to COVID-19. So next slide. Okay, so how about on the radiation oncology level? I think I'm speaking more from the perspective of our National Cancer Center in Singapore, where I think most other departments broadly followed the same response to COVID-19 in the sense that we split the department into two. National Cancer Center has the benefit of being split into two locations. For those of you who are familiar with the place, separated by buildings. And it was decided that there was enough staff for patients, doctors, and dosimetries, physicists, and so forth, not to cross over those two locations. In the private hospitals, what we did is that we split into shift systems as well. So it's a very similar concept, basically with the aim of ensuring BCP in the event of a positive COVID-19 case in either location. Okay, next slide. Okay, so how do we change our radiation treatment strategies? I think we are basically repeating what other countries have done. The aim was really to reduce visits to hospital, minimize their time spent in hospital. So we moved on to remote consultation by phone. Remote contouring and planning was on the cards, but it wasn't carried out as most staff was still based on site. So we didn't need to activate that measure. There was also permission to access results, approved treatments from home. And of course, as we all know, hypofractionation as far as possible was implemented. Next slide. I got 2 or 3 more slides and then we're done. Okay, MDTs, one of the questions, they were held remotely via tele or video conferencing. And I think that we have actually got better in it with time. And everyone gets used to seeing each other's faces on the screen and interpreting expressions behind the mask. Protocols were also set in place for management of COVID-19. Next slide. So actually Singapore was one of the countries which were quite active in publishing papers. So this is actually a paper published by a joint effort from the various institutions, from government and private sector, where we decide on the response. and how we handle a COVID-19 positive patients. Basically quite straightforward concepts, treating the patient the last day, PPE, designating a machine, a particular machine to treat those patients, and having terminal cleaning after use. So pretty standard measures. The reference is there, so we can always refer to that for further information. Okay, last slide. Second last slide, actually. So I think, again, hypofractionation, just quickly just tell you from a clinical aspect, what have we done so far? Palliative treatments, as you know, we've reduced the treatment to 1 to 5 fractions every day. Radical treatments, as far as possible, SBRT for early lung cancers has already been going on. We also tried to move treatment as far as possible to hypofractionation regimens, such as in prostate, where we use the CHIP trial more regularly, SBRTs, and so forth. Next slide. And finally, in the neoadjuvant and adjuvant setting, we also implemented the fast forward trials in breast cancer, in almost for all cases except where we need to treat the internal memory nodes. And of course, in the rectal setting, we moved more increasingly towards preoperative short course radiation for those patients. So just a brief introduction from the clinical aspect. So I think basically that's about all from Singapore's perspective. Thank you all for your attention, and we're happy to field any questions later on.
Thank you very much, David. And thank you for the nice background that you gave us.
You're most welcome.
Yes. We are really running beyond the time. We're almost 40 minutes beyond, but we could not really stop any of you because we are learning a lot from each of the 7 speakers tonight. All of you will agree with me that all the 7 presenters really gave a wealth of information, which is what FARO is all about. The reason why we are together is so that we can exchange our information, and then we can share, and then we can learn from each other. So things that came up tonight were hypofractionation. I think almost everybody is doing that now. And David, you mentioned about Zoom meetings, MDTs, we got used to looking at each other in the video panels. So, well, we really long to have our person-to-person, face-to-face contact, but maybe not very soon yet. So we will be content with all these meetings. But one thing nice about the Zoom meeting is that we can all be together more often than we would need to. So that saves us time from traveling, okay? So, all right. So again, on behalf of my other co-moderator, Professor Tati, you have something to say? We are about to close the meeting.
No, I think yeah, we are happy that we can be together, as you mentioned, and we will have the second webinar. Dr. Mayang will explain when will be the second webinar, and we would like to see you also in the second webinar. And thank you very much for all the participants for attending this webinar, and also to all the speakers. And we have here, and also we are very happy that we have here Professor Billy Manga, as well as Professor Nakano and Professor Dial, and also Dr. Zubi and Ben IEA, and all our friends are here. So we would like to thank to everybody. And also thank you to my residents for arranging this webinar. That's all maybe from me, Miriam.
Okay. So is there closing remarks from Maya? Or no more?
So,
yes.
So, Maya, do you have any more announcements?
Yes. Okay. So just a closing. So thank you very much for the session. And I would like to thank everyone for your participation today, especially the speakers and moderators, and of course, all attendees for making it a successful event. And then to all the members of the organizing team, the Aurora, Indonesian Radiation Oncology residents, under the supervision of ours. Thank you for great teamwork and all your hard work. And next slide is the last one. Don't forget to join us for the second session. It's exactly 2 weeks from now. We will continue to learn from the experience of the other 7 respected countries of FARO. Make sure you don't miss it. And this is a registration link. And if you cannot access the registration webpage, you can register through our email written there. So once again, thank you, everyone. Have a nice weekend. Stay safe and healthy wherever you are. And hereby, I close the session. Thank you.
Thank you and good
Thank
day.
you.
Thank you.
Can we have a photo of everybody?
Oh, yes, of course. The panelists may stay, please, for the speakers and the panelists.
Everybody have to video on.
You can have different groups.
For the panelists, please turn on your video.
Okay. The picture.
Photo.
Okay, I will take the picture and I will count 1, 2, and 3.
That's love.
Okay.
Okay.
Okay. Maybe once more. Sorry. Okay. 1, 2, and 3. Smile.
Wow.
Okay. Photo has been taken. Thank you very much.
Thank you.
Thank you. Thank you. Thank you, Ryan. Yeah.
Thank you, everyone.
Bye-bye.
Bye.
2 weeks.
Bye, Shyam. Bye, Tomo.
Bye. Bye. Bye.
Bye, everybody. Tomo, bye. Yunli,
Bye-bye.
bye.
Bye. Bye. Thank you.
Bye.
Bye.
Okay.
Sotita, bye.
Bye.
Bye. Bye.